Right, so good afternoon, colleagues, and welcome to the Ukzn-Echo outreach platform. This platform is a collaboration amongst the School of Clinical Medicine, the KZN Department of Health, Echo India, and the Echo Institute at the University of New Mexico in Albuquerque. So this collaboration enables a specialist faculty from the School of Clinical Medicine to share expert knowledge with healthcare workers managing patients at healthcare sites within KwaZulu-Natal to improve patient outcomes and quality of life. So we're very fortunate today to have with us Dr. Safia Osman, who's from the Department of Plastics and Reconstructive Surgery from Nkosi Albert Luthuli Hospital. And she's going to be presenting today's session on skin tumors. But before I hand over to Dr. Osman, who will give you an overview of the session, just a reminder about video conferencing etiquette for this session. Please ensure that your mic is on mute and that your name is visible in the participant list. Raise your hand or post a question in the chat during the Q&A session. And with that, I just hand you now over to Dr. Osman.
Thank you. Good afternoon, everybody. Thank you for joining us. So I'm going to be presenting on skin cancers, and this is basically directed at the PHC, also base hospitals, nurses, interns, medical officers, basically to give you an approach on how to manage a skin lesion and where to go from there. We may have the dermatologist joining in as well, just to give you all some input. And I'll present some clinical cases just to let you know what we would have expected to have been done, and then just to show you all what the surgeries we perform and what our unit is capable of. Okay, so as I mentioned, I'll show you approach the skin lesion and the role of a plastic surgeon in the case series. Skin cancers are locally destructive malignant growth of the skin which originate from the dermis, and broadly we manage them as melanomatous skin cancers and non-melanomatous skin cancers, and these two are very different. Any skin cancer can arise from different origins. If it's epithelial, the more common BCCs, which is very mild, and then you have the squamous cell cancers, which are in comparison to BCCs much more aggressive. But still, we have many patients with BCCs and SCCs that we can just manage with basic excision and primary closure, the larger majority of them. Skin lesions can occur from appendage origins, and you don't actually really need to know too much about them. Just making sure that we have a diagnosis so then the patients can come across and we can then take over the management. And then we have lesions of mesenchymal region where we get dermatofibrosarcoma protuberans or Kaposi sarcoma, which is common in the HIV setting, and that actually goes to the hematologist. So, as I mentioned, they really metastasize or become life-threatening unless it's a malignant melanoma. And a small, tiny malignant melanoma can have the very short survival time. So that's something we treat very differently to the non-melanomatous skin cancers. So when you have a patient with a skin lesion, like any patient, you go through history examination and investigations. And when taking a history, you need to find out when did this lesion start, how long is it there for, has there been any changes, has it been biopsied before, was there any medical or surgical management? And then you look at the general risk factors of the patient. Is there albino, sun exposure, is there any chemical exposure, what is their occupations? And then also to have an idea of their past medical surgical history and well as allergies, because that may not necessarily always play a role in terms of determining why the patient has a skin lesion, but it assists us in determining how fit is this patient to have a procedure done. because especially when we get extensive lesions, some of our patients are unfit for a general anesthetic and then move on to the oncologist for things like palliative chemo or radiation. So in examining the lesion, take note of the size. It's helpful to keep a ruler to measure, look at the color, elevation, is there any ulceration, is there rolled edges? Is a lesion mobile or is it fixed to underlying structures? Is it fixed to the fascia? Is it fixed to muscle or bone? And then also to look at the sensation in the area, which may not always be relevant, but in particular, like the lip, if you have a lesion on the lip and you have numbness, then it would indicate deeper invasion and involvement of the mental nerve. And then particularly paying attention to the lymph node basins, especially since we get many skin cancers on the head and neck region. A thorough examination of the preauricular area, the parotid gland, the postauricular, and then looking at all the neck zones. If there's something on the torso, it's important to check the axilla as well as the groin because it can drain either way depending where these lesions are. And in particular to the lower limb to check the groin. So the ABCDE system is used particularly with pigmented lesions in assessment of melanoma. So you look at the asymmetry, is there border irregularity, is there color variation, is it more than 6 millimeters, and if there's elevation which suggests an aggressive vertical growth. And this is particularly used when screening patients who have moles or a congenital nevi or any other sort of nevi when you're trying to monitor for a change in that lesion to progress to a melanomatous skin lesion. So this is just a table looking at a normal mole versus a melanoma where there's asymmetry seen in the melanoma. In the second row, you can see in a normal mole, a well-defined lesion as opposed to an irregular one in a melanoma. And then when you're looking at the color in a normal mole, it's more uniform as opposed to the variation in melanoma on the right. And then looking at diameter, moles tend to be smaller, although this is not an absolute finding. Then moving on to investigations. We don't often need chest x-rays and etc. But if you have a large lesion that's fixed, especially say, for instance, over the lip or mandible, then you do an x-ray to just look at if there's a bone reaction. And that prompts you more to move on to something like a CT scan, which would be like a CT head and neck. And these are things which we do require the base hospitals to do and send us the disc with the CT report to avoid bombarding a tertiary institution having to do these scans. And the most basic thing we require is for a punch biopsy to be done. Just to look at how a punch biopsy is done, we prefer using dental syringes to inject the area to numb. You directly inject into the area that you would be biopsying. You don't necessarily need to do a nerve block, although sometimes that could be helpful. The punch biopsy comes in varying diameters. For a small lesion, you can use between 3 and 6 millimeters. If it's a very tiny lesion and you use a very big punch, you may just end up doing an excision biopsy, so just be wary of that. You basically apply pressure and you turn it in clockwise or anti-clockwise direction and take a full thickness skin biopsy. Sometimes the tissue can get stuck within the core. You can use a needle to try and retrieve it. And this is then sent in formalin to the histopathology lab. And please get the formal print out I know sometimes the peripheral hospitals don't even have a functioning printer. At least write in your referral letter the RS number with the relevant details of the lesion. So if there's a specific description when it comes to, say, for example, a basal cell, if it says it's nodular or micronodular, please note these things down because it does affect our decisions. And it's not something that I need to cover in depth because we don't expect you to be managing these cases. The purpose of today's talk is to basically show you how to get these patients to us and to also have the least amount of hospital visits and up and down between hospitals for the patients because our patients are coming from far and wide and it's quite costly for them. So if you do perform an excision biopsy, sometimes you'll feel it's small, it can be closed primarily. Maybe you're not suspecting a cancer. Irrespective, any tissue that's removed from the patient must be sent for pathology. And just for you all to learn how to orientate specimens, because sometimes you get caught off guard and you have a malignancy. We need to have an idea of what sort of margins were taken. So we routinely use it's not maybe possible in all patients, especially when you have a three-dimensional tumor to label. But generally with skin lesions, we put a suture at 12 o'clock. So the code is SSS, short suture superior, and long lateral, we put at 3 o'clock. You can put a short suture at 3 o'clock, whatever you want to do. It's just nice for us to be uniform and try and follow these rules so that we, in case we forget or a note is not written down, we can assume that these are where the sutures are placed. So you need to write down in your lab form and in your notes what suture you put where so that the pathologist looking at it can report the margins accordingly, and the person who's the surgeon who may be looking at your notes can tell what needs to be re-excised if there's a close margin or an incomplete margin. So I mentioned earlier a CT scan. If the lesion is fixed, if the patient has nodes, or if it's a very large tumor, a CT would be required. And the most common area is our head and neck lesions where we need a CT head and neck with contrast, please. So when you see this patient, take the biopsy, pull the UNEs, book their scans so that the next visit would be at the CT scan date, and then they'd see you with all the results. Just to try and streamline how patients get the investigations done and they can get all the results and be sent to us. So I'm going to go through cases and just to give you all an idea of what we would have expected you all to have done, and then just to let you know what we would have done. So in this case, this patient had a lesion on the lip. It was for 2 years. He was a smoker. What we would have expected to have been done is counsel the patient to stop smoking, sun protection, take a biopsy. It was a mobile lesion. It was only within the lip. There were no nodes in the neck. We have expected a punch biopsy to be done. If you had any comorbidities, you could have taken basic bloods. But really what we need is mainly the biopsy. And then you can send the patient you can refer the patient on VULA. We performed an excision and I think it was a wedge excision and a primary closure. That's something that we do not expect the peripheral hospitals to do. That is something that we are happy to do. And these cases are actually done under local anesthetic. So it's a day procedure. The patient comes in the morning and leaves in the afternoon. Also, before I forget, please, when you're referring patients to us, they need to be informed that their visit is the first visit with us, where we will then schedule their theater dates. Often patients come expecting to be operated on the same day or to be admitted on their first visit with us. And that's not really possible because we need to assess the patients for ourselves and do the appropriate bookings. So the next case is an extreme case. This is an old patient. He sat at home with this lesion. This was actually a basal cell cancer, and he was a COPD patient with uncontrolled hypertension, not well. He did not have metastatic disease, so he did not require a neck dissection. And radiation would have affected his good eye, since he had one good eye. So we would have expected a chest X-ray and ECG to have been done, a good letter in detailing his medical comorbidities, what medications he's on, because these patients are old. They don't know what medications they are on. And we need to have an idea of what sort of control they have. We would have expected an incision biopsy, um, and we would have expected a CT head and neck scan to be done. And in terms of further things like a pulmonary function test or stress ECG, that's something we can sort out. So we will get the patient seen by the pre-anesthetic clinic on our side, and then we can then sort out the rest of those sorts of tests at Albert Luthuli. This patient in the end basically he did have a general anesthetic. He was optimized. We did a wide local excision. We did not reconstruct the nose. He lost the right side of the nose, and his septum was still left intact. He did subsequently have multiple small recurrences, which is exactly why we did not reconstruct him in an extensive tumor like this. So we can manage each recurrence on its merit. He had a transposition flap from his right cheek to cover the lower lid defect as well as the residual cheek defect. This lady had an SCC of it was the nasojugal area, a bit of the nose. So we expected just the medical comorbidities to be detailed on the letter and her compliance of what her medication was, and a punch biopsy. She did not require any X-rays or CT scans. She had no neck nodes. It was a mobile lesion, and we took her to theater. We did a wide local excision. We did frozen sections to ensure that we had clear margins so that we could cover her with a flap. So if we have skin lesions in sensitive areas where we may cheat on the margins, or if we have lesions where we'd like to cover with a flap, we preferably like to get frozen sections, because putting a flap on a wound conceals recurrence. So a primary closure or a skin graft is better when you have concern for margins. So in this case, we had no concern because we had frozen sections, and then we reconstructed her with a nasolabial flap, which we transposed to reconstruct the nose, and then we reconstructed the cheek by advancing the rest of the cheek in. This is a bit of a complicated recon for you all to understand, but just to show you all the kinds of cases we perform. And the idea of taking the nasolabial is that we hid the scars in the nasolabial fold. She actually healed quite nicely. This is a patient with an extensive squamous cell cancer in the temporal area, pretty similar to the patient on the cover slide. That is actually a tape gauze with TV code that's stapled onto the lesion. So it's our way of trying to control the contamination during the excision, so that other than tumor cells, we're actually more worried about the colonized area where we have high rates of infection when dealing with these ulcerative lesions. So he required excision of that the temporal area with the underlying muscle, and this was a defect he had post-excision, where he had bone exposed. I think I excised a bit of sarcoma in this area, in this patient. And we did frozen sections. We had clear margins, and then we opted to do a scalp flap. So we transposed the scalp. The area where you can see rest-on form is actually where the scalp was taken from, and it's transposed to cover this. The reason why this rest-on form is because the donor site is raised above the pericranium, so that it's a graftable base. We then take a split thickness skin graft from the thigh and apply that onto the donor site. And that's basically a bolster dressing where we put Gelonet, and that we have acroflavin soaked in cotton wool, and then we apply the rest-on foam so that there's no movement and shearing of the skin graft so that that can take. Then we have a drain placed under because of the risk of hematoma. The scalp bleeds a lot. And then this patient actually refused, he defaulted his radiation. He had a paroidectomy and a neck dissection done on the same day after this picture was taken. And he has come back with a recurrence because he failed to attend his radiation. This is a lip lesion, similar to the other one. I've just got pictures here to show you the kind of excision and the local flap advancement we did to reconstruct the lip. So if we are taking a 5 millimeters or a 1 centimeter margin and we're happy with it macroscopically, we don't always send for frozen sections because we've taken large margins. It's usually when we take less cheat on our margins, basically for cosmetically sensitive areas like the eyelid and nose, and sometimes the lip, that we make sure we have frozen sections. This is another lip lesion. We also would have expected a punch biopsy. This patient was otherwise well. And in the case of RBD positive patients, please send their CD4 counts and viral loads with the patients. They often just are told whether it's good or not, and they don't know the actual figures. And it's quite important because we do such extensive surgeries and the patients often have to go to ICU post-op. In the case of like the free flaps, which I'll show you later, it's quite futile to take a patient who's immunosuppressed and unwell because they can't withstand just the anesthetic alone or the prolonged surgery or the prolonged hospital stay, because if there are any sort of complications and they have a prolonged ICU stay, they are less resilient to the hospital-acquired infections like pneumonias, etc., that happen in ICU. So this is a patient post wide local excision, and then we did a local flap reconstruction. And the aim of our reconstructions is, one is it is aesthetically pleasing. And these are not completely healed, but the idea is the donor sites are all concealed in natural lines. And the most important part is the functional results, where we are able to maintain muscle innervation and continuity. So when cutting through the lip, we then suture the muscles together so that we still have a sphincter. And this is a patient like the other patient, but this was a younger lady who had a wide local excision. She had zygoma excised, lateral orbital wall, and pediorbita. And I didn't have a picture of her donor site, but this is an example of a radial forearm flap where we take the skin with the subcutaneous tissue and fascia with the radial artery, provided the Allen's test is fine and the hand can survive on the ulnar artery supply alone. And then this is in anastomosed in the neck. And this makes it possible for a patient with an extensive lesion like this to be radiated. So often we have patients who have a graftable wound base post-excision that can even take a skin graft. But if they require radiation, you cannot radiate a skin graft. Well, there is some possibilities when it comes to certain other things with an electron, but largely for treating these squamous cell cancers in particular, they need a flap cover. So this is just a picture of our team with our consultants at the top and Prof. Madari at the bottom right, and the rest of our team of the medical officers and registrars. We are reachable on Vula. Most of our skin cancers are directly referred from the dermatologist, so that is the way to go. They should be seen at the skin clinics and then referred on to us. And there isn't a special arrangement between the dermatologist and us, where they actually don't send these referrals on Vola necessarily. They have a performer with us where they fill in the results and they discuss with their consultants. And if their consultants are happy, they call and book directly with our clinic. But if you are referring outside the skin clinics, please contact us on Vula, and we will give you the advice that's needed as well as a password so that you can call our clinic, which is extension 1889 at Albert Luthuli. Sorry, it's 240-1889 to make the appointments for the patients. Thank you.
All right. So thank you, Dr. Osman, for this presentation. Are there any questions from the audience? You're welcome to unmute. Do you have any questions either related to this presentation or any other questions you may have related to skin tumors? I see that there are some dermatologists online. So, Dr. Ngobo, welcome. Do you have any comments on this presentation? Or would you like to add to that and just tell us how maybe the dermatologists begin the investigation before referring to the Department of Plastics and Reconstructive Surgery? Dr. Ngobo? I think Dr. Ngobo is going to unmute. Another question.
Oh, hi. Hello. Can you hear me?
I can now. Welcome. How are you?
Yes. Hi. Hello. Thank you, Cyrilla, for reminding me. Shame. I've had such a busy clinic today. I saw the invite. Shame Prophet posted it early in the morning today. Thank you so much for the presentation. I joined very late because of the busy clinic. But yes, I remember as well last year when we had this talk, very important, especially to emphasize the need for clinical clues in terms of at the base where the patients are initially seen before they even reach us, to be able to note a non-healing ulcer not to be treated for a long time in the local clinic is very important. And for us, it's usually very easier. We have a good working relationship with plastics, and even more so where we had the MDT, multidisciplinary clinic at Albert Luthuli. So we've referred a number of these patients, very extensive. It's very sad when patients present with such large, expanding lesions that even sometimes come with nerve pain on the face. And it's such a remarkable work that you do with your team. It's unbelievable when every time we keep seeing what you do and the reconstruction that you do for these patients, where initially we would be so overwhelmed about how much is going to be taken in terms of wide local excision, but the work you do in reconstruction is amazing. It's amazing. And I think the other group of patients that we see, again, it's where we do education, about the changing moles. For patients with melanocytic nevi, they need to know the examination of patients. We've referred to quite a number, actually, that were incidental finding, that the dark-skinned patient has these pigmented lesions on the acral on aspect of their feet, as in the soles. So I think the other group of patients, the at risk that we see a lot, are patients with albinism. A number of them, despite that we follow them up when they're still very young, they do get followed up in the clinic for education and being able to be able to see suspicious lesions, but we still see them presenting with extensive skin cancers, especially the non-melanoma type of skin cancers. Yeah, I think that's what I would love to have added in terms of the education, and early presentation for these patients becomes a real problem that needs a wider education that reach these patients.
Right, so thank you, Dr. Ngobo. Do you want to comment, Dr. Osman?
Thank you for the feedback. I wanted to ask if there are any nurses from the PHCs online, if they feel there's something they're not comfortable managing or doing, or are there challenges getting like a non-healing ulcer across? If they can just let us know so we can see how we can help. Is there some sort of outreach that needs to be done? I mean, I don't expect the nurses to have to be doing punch biopsies, but are there any challenges in the PHCs?
No? So do we have anyone online from a PHC clinic or a CHC perhaps would like to comment?
So sometimes we have patients coming across and saying, no, I've been going to the clinic for a long time and they've been dressing this wound. So it shouldn't take such a long time for them to then be referred on. And that's really, if I had one aim for this talk, is to get to the PHCs for those kind of patients who get delayed and lost in the system. And it should never happen to an albino patient. And I think the skin clinics, the dermatologists would never refuse to see those patients. So that shouldn't be a challenge. It's often, I think, just the know how to think, okay, I need to refer this patient on.
Okay, so we did hear from Dr. Ngobo that a non-healing ulcer must be, a practitioner must become suspicious when there's a non-healing ulcer. Are there any other take-home messages? Because the cases that you presented all seem quite obvious. They seem quite advanced and obvious. But where does it start in terms of it arousing a suspicion that this is more than just an ulcer?
So a persistent lesion that's not healing, that has rolled edges, that's ulcerative, it should go to a skin clinic and they can evaluate it, because remember, there's a lot of patients who have venous ulcers and arterial ulcers. Those are not to be necessarily referred to us. We need to look at the patient in it holistically and look, do they have varicose veins, do other pulses present? And it can occur that you can get a marginance, which is a squamous cell cancer in a chronic wound. So if we are treating the arterial and venous disease and dressing wounds or skin grafting, they're not taking, one should also bear in mind that you should do multiple punch biopsies within those wounds so that we know we're not missing a skin, a conversion really in those wounds. Growing lesions, associated lymph nodes, fixity, they need to be assessed, at least at a district level.
Okay, and if they have a suspicion, if the practitioner has a suspicion, then they can contact John and Buddha.
Yes, because it doesn't mean that we have to, that you can't contact us and we just for advice. Minor things we can advise you on. It doesn't necessarily mean the patient has to come all the way here.
Okay, there were some rehabilitation therapists online. I see they're, they might still be there. So I was wondering, maybe you can just, you've done such amazing surgery, and even Dr. Ngobo has been so complimentary.
She always is, thank you.
So maybe I don't know how often the rehabilitation therapists actually engage directly with the surgeons. And what advice can you give in terms of post-op rehab, and then from your center, and then even going back to the base hospital and even home-based care? If you can just give us,
Okay, so in terms of the rehab, I feel like it may not necessarily involve skin cancers too much, but it involves plastics in general because we manage so many other things. In terms of the need for physios and occupational therapists, if we have, okay, let's just talk about skin cancers and keep it there. If you have skin grafts on a limb, particularly the hand or any joint, and then the lower limb, skin grafts have to be immobilized for at least 3 weeks. Patients need to be on bed rest, they need splints, they need to be on anticoagulation to prevent DVTs. They are often stiff, but if you don't immobilize them, the grafts will initially look great and then they will fall off. They won't take, they'll be shearing, etc. So they do need rehabilitation, is particularly with the hands, because once they get stiff, it's a really intense physio that needs to be done to get them back to their baseline function. And I know the challenges that the physios and OTs are facing with the low numbers. And I don't know what we're going to do about that, because patients go to base and then they get a 3-month appointment, and it's really not enough, because they never recover the function in their hand, and their hand was fully, like, could have been back to normal had they had the adequate physio. So we actually keep our patients admitted if we have beds for a long time, just to make sure that we can get them mobilized. And that's obviously a month down the line, because now we have our grafts taken. When it comes to head and neck, like outside skin cancers, when we're doing tongue reconstructions, floor of mouth, etc., swallowing is a problem. And then we need the assistance of the speech therapist to assist with speech and swallowing, and then assisting in reteaching patients how to swallow certain foods, or even how to modify their foods, and that's where the dietitians come into place. And then one other thing, maybe not necessarily related to physio, OT, and speech therapy, is when our patients are post-surgery and healed, or even if they come into the local clinic for dressings, the importance of compliance for those patients to come back and complete their radiation. I mean, 2 of those cases, I presented them last year, have since recurred because they did not go for radiation, or they had radiation and they still had a recurrence because they're such aggressive tumors to begin with. It's not that the surgery was necessarily inadequate. It's important in picking these lesions up early and ensuring that patients attend their oncology appointments, because it's a large expenditure. It's a lot that's invested in terms of time, theater time, ICU time, ward time, and then the patients are not doing well long term.
Okay, so that's great, Dr. Osman. I was just saying, just in terms of, I'll just go back to the rehab and then probably ask one question. If you talked about the hands, if the patient presented with tumor on the hand and then we had a graft post surgery, would the rehab begin at a passive level, or would you encourage active movement?
It starts with passive and then
within a particular range, or how does it work?
See, with hands, it's different when you're talking about just a skin graft versus a tendon reconstruction. So when it comes to tendon reconstructions, yes, we go passive and then active. But when it comes to a skin graft, if the skin graft is consolidated, they can go active and passive, but they aren't able to do as much active as they do passive. So it's very important, especially to flex the MCPJs, because that's when the collaterals are at the maximum length. And that's the crucial part. Somehow they may get the interphalangeal joints moving, but once the metacarpophalangeal joints are stiff, they basically need capsulotomies and further surgery, which needs active physio thereafter, and we just don't have the ancillary services to maintain that rehab. So we should need to prevent it from the get-go.
Yeah, absolutely. And so you spoke about the and Dr. Ntobo as well talked about the MDT team. But then you also highlight how patients are not fully aware of the follow-up in terms of radiation, and those then have consequences for,
So well, the oncologists, we actually had this chat with them. They're saying that the compliance is good, but the problems we have when patients fall ill in the interim and say miss an appointment, they need assistance from their base hospitals to go and remake those appointments. And I think that's where we are losing them. Or if they miss a bus or they forget to book transport. So I think when the patients come back, they always have a discharge summary with all the dates, and the nurses need to take responsibility and just maybe baby these sorts of patients and just make sure that everything is booked for them before they go home, because it's not easy for these patients to even pick up the phone and call the hospital. It's hard to get through in terms of trying to get a bus booked or things like that.
Okay, so just Dr. Ntobo, I see your hand. I just want to just ask one last question, just in terms of the team. Who would then be the leader of this team in terms of, ensuring that the patient follows through with the well, it seems like a range of services that they need to access? Who would be monitoring this patient? Is it in your domain, or is it the dermatologist?
So the patient is basically handed over from one discipline to the next. So once the biopsies are done and it needs us, it would come to us and probably stay with us. And then from us, once we're done with the surgery, the patient's then handed over to the oncology team. So when they are done, they have follow-up appointments, which you try to have on the same day, even if we're not seeing them concurrently, just to avoid multiple hospital visits. But there is a skin MDT that occurs in oncology, but it's usually our very extensive patients who have difficult decisions to be made, but not straightforward things. But for the vast majority, they hand it over, and then after everything is done, then they would go back to the skin clinic for surveillance.
Okay, I hear that. But I'm just trying to see how we can where we can identify the break, and if we can close that gap. Dr. Ntobo, please go ahead.
Dr. Osman has actually covered what I wanted to mention as well, in terms of the follow-up, and when patients sometimes may get lost in the system when they miss the date, and I don't know whether scared to be confronted about missing the date, that they actually, fall into relapse, or, even not being followed up properly. So very important to touch that point. And again, if these patients present, whether at the base local clinic, always to be aware of these previous history of them being having excised lesions that were suspicious, and even more so confirmed as skin cancers, particularly those patients that we know are at risk in terms of the at-risk group, like the patients with albinism. Then one other thing I wanted to emphasize is the use of VULA. It has really helped a lot in terms of getting this patient across earlier, where we can share even the pictures, and the doctors across at Albert Luthuli are able to expedite these appointments for those who need it. So if maybe doctors in the outreach areas and the rural areas could have access more to these facilities. One last thing, Dr. Osman, is about patients who have had, excisions done, and they feel or actually present to be having, some pain or numbness, or even a growth that we can see that there's the change around the area of the old incision. Should we be biopsying this patient as a query recurrence, or should we just discuss with you, even if it's on Vula, to get an opinion whether we need to biopsy before sending them across to you? Especially if it's in the areas where danger zones on the face, should we attempt to rebiopsy them, or should we discuss? What would you advise?
I don't know if you have a particular patient in mind, but I do. But if there is an incision over it and it's palpable, you can do an incision biopsy. But if you're not comfortable, then you can refer it on, especially when you're saying danger zones. Because are you referring to patients where basically you can see a mass subcutaneously, you can feel it, and the skin is not necessarily abnormal? Then sometimes we opt to actually image these patients sometimes first and then biopsy.
Yeah, okay. So it's for both, where you can feel there could be like a subcutaneous element to the old scar, or danger zone is in the areas where the patient who has had an excision close to the eye, and you're worried, canthus, so it's too close to the eye corner there, and we worry about biopsying such area with previous, surgery in that area.
As long as there is some skin changes, we'll have to excise that cancer. So I think for the patient's sake, in terms of timelines, you should try to take a biopsy. And if you're not comfortable with a punch in that kind of area, then do an incision biopsy rather. So you can take a smaller piece and you're able to grab it with a forceps, and um yeah, I would think an incision biopsy you should rather.
Okay, thank you.
You so much, Dr. Ngo, for joining us. Thank you for your questions. And then we have another plastic surgeon online, Dr. Mukama. Do you have any comments, Dr. Mukama? No, Dr. Mukama is not there. Okay. All right. Are there any other questions? Any comments? Yeah. Are there? Is there anything else you would like us to feature?
Hi.
Dr. Mukama? Oh, there you are. Hello, good afternoon. How nice of you to join us.
No, thank you. Thank you, Dr. Osman, for a very good presentation. I think you've touched on all the very important points, and I think one of the things that has already been brought up, I'd like to just emphasize, is the availability of VULA. Discussing cases from a primary healthcare level, even if it's a nurse or the doctor that's dealing with it, it really can add to patient management. And those patients that need to have expedited dates, or that need to have treatment that's outside of the norm, can be identified, and then we can say, with this type of patient, please send to us quickly, or else we can give advice that with this type of patient, please biopsy and then send to dermatology and that sort of thing. So discussion is welcome, and pleased to use that as an avenue to differentiate which patients are the worrying patients and which ones, can you use the usual referral route. The other thing that I just wanted to also bring up with skin cancers is that we often find that, especially with the high-risk groups, patients with albinism, they often get multiple cancers. And I think as healthcare providers, we also must just remember that they can get quite despondent, saying, I went for treatment for this one, and then now I have another cancer, it's coming back, it's not treated. Particularly with the patients that have a high risk, they can get multiple cancers. It's not necessarily a recurrence of the previous one, but they can get multiple new lesions, and it's not necessarily related to the old lesion. And it's important for us to communicate that with patients in the clinics when we see them. You've got one cancer, and therefore the risk of getting another cancer is also high.
Right. Thank you very much, Dr. Mukama. Do you have any comments, Dr. Osman?
No, thank you. Thanks.
No, okay. All right. So before you leave, audience, please may I encourage you to go to the chat and just to complete a very, very quick questionnaire, giving us feedback on the session. That's the way in which we can improve the session and also then shape it more to your requirements. All right. So if you just go into the chat, there's a link. Click on the link, and then there's a very quick survey that you can complete, and we will be immediately able to access your responses. Are there any other questions or comments for Dr. Osman? Oh, well, then thank you very much. And then Dr. Osman, thank you again very much for this insightful presentation. I just want to say our next presentation by the Department of Plastics and Reconstructive Surgery is scheduled for the 20th of March, same time, 2:30 South African Standard Time. And it's on wound healing and dressing. So please look out for the advert. All right, and with that, I'd just like to say thank you very much again to the Department of Plastics and Reconstructive Surgery. Thank you also very much, especially to Dr. Osman for putting this together, for actually coordinating all of these sessions for us as well. And to the dermatologist, Dr. Ngobo and her team for joining us as well. A big thank you also goes out to Echo India for the technical support, to the College of Health Sciences UKZN IT support team, and the School of Clinical Medicine Administration, and in particular to Professor Glover for bringing this facility to us so that we can outreach to the province of KwaZulu-Natal and beyond. And with that, I want to thank you for your participation and thank you for making the time to join us. And we look forward to your comments on the feedback. Thank you very much and goodbye.